Welcome to the Vatech Education webinar series for 2021. I am Jim Mayer, Education Team Director. I have the pleasure of working with Paul Satone. Welcome, Paul.
Thanks, Jim. Really great to be back for another monthly webinar into a new year this year, so really excited to be here.
Yes, we started this series back in April, bringing on some of the best key opinion leaders in the dental industry, and we are continuing into 2021. Today, we are starting with the title, Unleash the Power of CBCT in Your Dental Practice, presented by Mr. Lennart Elgaard here at Vatech America. Lennart will be joining us here in a few minutes. Paul, what is the focus of today's session?
Yeah, so Len's going to discuss, things surrounding the myths of CBCT, really establishing a digital workflow, using CBCT to overcome blindness in treatment, and oral sleep analysis and whole body health, and really discussing CBCT and taking it into the future as far as your practice goes.
Yeah, and that overcoming blindness using CBCT, we're going to look at 4 or 5 specific cases. We'll touch on different aspects of cone beam and clinical presentations there too. So some good stuff coming up today.
Yeah, for sure. Okay, so we're going to continue into 2021, with our Key Opinion Leader series, starting with today and then following next month, continuing with every Wednesday, first Wednesday of the month. Next February the 3rd, we'll be having Dr. John Tucker with us, discussing implants and obstructive sleep apnea on that session. So he'll be discussing things such as obstructive sleep apnea and the impact of the airway on implant success, patient screenings on OSA and parafunction, and really discussing the different treatment options for you and your patients. So that'll be a great session on February 3rd. And then into March 3rd, again, the first Wednesday, we'll be welcoming back Dr. Dale Miles to discuss understanding how CBCT can ensure implant success and prevent failures. So he'll be discussing things like identifying pitfalls during patient assessment for implant planning, and really examining and discussing common causes for implant failure. So we have a couple great webinars coming up on that end. And as always, you can sign up on our website, vatechamerica.com, and they've added a link right on the main homepage in the upper left-hand corner to sign up.
Yes, some exciting opportunities coming up later in 2021. Paul, we also launched last year the Fast Track Friday series, where we reviewed workflow of specific to the Vatech product line. We have expanded that series out to several Fridays a month now. So coming up next Friday, January 15th, we're going to be working with EasyDent Eye and our intraoral sensors. So if we have any users of our intraoral sensors, or if you're interested in the two-dimensional intraoral imaging aspect of the Vatech brand, you can tune in and we will have an interactive question and answer session. And these sessions are meant to be for the entire dental staff, not just for the doctor. So we want to incorporate the office manager, front desk, hygienist assistants, and the doctor to bring a synergy to your office, maximizing the use for our Vatech product line. The following January 22nd, we're going to focus on imaging workflow and patient positioning specific to the extraoral 2D and 3D cone beam technology, and that's going to be January 22nd. And then January 29th, we're going to move into some more 3DI software case planning, where we're going to review 3 or 4 specific individual cases, work through case planning, understanding the cone beam software. All of these sessions on these Fridays are 8 through 9:30 Pacific, 11 through 12:30 Eastern. So we want to make it a nice applicable chunk of time to really cover some good topics here.
Yep. Yeah, and any feedback on these or any future webinars, please feel free to email us at these email addresses on the screen: sales, questions for the education team, or customer support there, or also on our social channels. Feel free to reach out on Facebook, Instagram, and LinkedIn at the handle @Vatech America. So lots of ways to get in touch with us.
Yes. Everyone, We are on the GoToWebinar session. I like to call this a little housekeeping, just so everyone can realize how to navigate through. You can see the presenter at the top of the screen. There, you can expand or collapse that portion. And then off to the right will be your control panel of your audio and where you can do some Q&A. So if you do see your audio, if you are logged in via the computer and you're having any computer audio issues, click on that help button to troubleshoot that. If you continue to have issues, I always recommend just going ahead and phoning in. Just note everyone will be muted. Different ways to connect with us. There is a chat button that you can chat with us, but this will be a question and answer session today, so we will have time to interact with the Vatech education team, Paul, myself, and our team behind the scenes. And also we'll be chatting and communicating with Mr. Lennart Elgaard as he presents. So feel free to go ahead and ask any questions on there. Unfortunately, we are not providing any CE for today's sessions. However, coming up in February and March, there will be CE provided with those sessions there. If anyone did come prepared with any questions, feel free to go over to that Q&A button and type that in, and we can go ahead and address those throughout and immediately after the presentation today. So I would like to introduce Mr. Lennart Elgaard. He is the Director of Strategic Partnership and Development here at Vatech America. I've had the pleasure of working with Len since 2011 when he came on board. He has held the position of Education Specialist, Director of Education. He is currently the Director of Strategic Partnership and Development. He shares his knowledge to maximize image quality, elevate diagnostic treatment planning capabilities, and increase workflow efficiency for thousands of dental practices throughout the United States, Canada, and Mexico. In recent years and currently, he is conducting lectures discussing the benefits of digital radiography with an emphasis on 3D technology at various symposiums, dental conferences, and dental courses across the country. Len, welcome, and thank you for joining us today for your presentation.
Well, thank you, Jim. Thank you, Paul. Thank you. I feel both honored and it's a pleasure to be the first guest speaker of 2021. And for everyone attending here, I certainly wish everyone health. Let me just make sure I got connected here on my screen, and I should get them going here in a second. All right. Just to give me a thumbs up, I have my screen running, and let me know if you can see it then as well. Perfect, good deal. So certainly, again, I wish everybody Happy New Year, a healthy and prosperous 2021. I thought this was a good topic to discuss in the first presentation for 2021, seeing that a lot of the events we're going to be doing on a monthly basis, even these Fast Track Friday sessions, really focus a lot on CBCT. So I really feel it's essential to have a good, firm understanding of the power of CBCT that I can offer for the dental office. And this really extends to not only those that are considering CBCT for their practice, those that have just implemented it, maybe are novice, and even those who are considered to be an expert in terms of CBC implementation within their practice, and maybe perhaps looking to expand how they use their technology as well. So try to cover cases that really hit on everything that you would come across within your dental practice. So with that being said, one of the things I certainly want to encourage everyone to do as we go through this tonight, certainly want to make this as interactive as possible. So I want to make sure that we answer your questions going through this here, keeping in mind as well the fact that this entire session is being recorded. So when you have an opportunity, you can go to our website where you can then access the recorded session for this. Certainly, as I come across something, if you want me to go into in greater depth in terms of clarity, further explanation, feel free to let me know. I want to make this as interactive as possible for our session here tonight. So let's go ahead and jump into it. There's a lot of content, so I'll briefly go through the table of contents here for our session tonight. And the first thing we're going to be talking about is basically using 2D and 3D radiography in your dental office. And we're going to break it down, talking about the fact that there is still certainly, a practical use for 2D radiography and other imaging systems within your practice. Okay. Also, I want to make sure that there are some drawbacks that we're aware of when it comes to using 2D radiography. And with that, using it as the benchmark in terms of introduction to discussing what I can refer to for many years now, what I call the myths and reality between 3D, the perceptions that people seem to hold on to after all these years, and creating a reality so that way we can properly educate not only those that are attending the session here tonight, but I feel it's just as valuable to educate the people in your office, clinical team, as well as your patients. Okay? The more you can educate the patient, the more cooperative they can be, and ultimately get higher case acceptance as well. So once we get beyond that, we start talking about how to unleash these benefits within your practice as well. So we're going to cover a number of different cases, and I put the term, curing blindness in parentheses. Obviously, we're not an eye care clinic, but you're going to see that when you start expanding from 2D into 3D, we're start seeing things from other angles rather than from a 2D radiography type of view. Expanding your view in terms of just focusing on not only just the area of concern, but overall or other areas within the scan to help improve overall health of your patient as well. Also looking at the OSA, and I'll use the term paradigm shift. This was often used by one of our thought leaders, and I'll talk about that in a little while as well, and how we need to kind of re-educate ourselves in terms of how we discuss airway in the community. Permanent dentures. We can talk about that and the 10% market that I'll refer to in greater detail here in a little while. And then using all that and being able to maximize all this within your practice, be able to create efficiency and effectiveness in terms of your case planning within your practice, and really making sure that we talk about image capture protocols. Then also, again, all comes down to education. The more you can educate yourself, your team, and your patients, where everyone's going to be in terms of utilizing our technology, again, getting this increased case acceptance. With that being said, let me go ahead and jump into this here. So, talking about 2D radiography in the dental practice itself, okay? So, certainly there's still value in 2D radiography. There's a list that I have here, such as, looking at third molar extractions, looking at early indications for orthodontic problems, assessment for potential implant sites, okay? Elimination of gagging for patients, because now you're not using an intraoral sensor, which can be more invasive for some patients, okay? Evaluation for bone loss, certainly, and also as general consultation for a patient, because most patients, when looking at an image like this, should be able to interpret the anatomy fairly easily, okay? Now, Dr. Parashar, who is one of our references that we use quite a bit, put together this listing of 57 anatomical reasons to choose a panoramic survey. So obviously for time, I won't go through all of them, but certainly when you get opportunity, you go to the recorded session, and it goes through this in great detail to identify all the craniofacial aspects of our anatomy that can be rendered from a panorama survey, okay? Now, this certainly extends to other types of 2D radiography, such as lateral views, PA views, Karpa's views that are used in orthodontics and oral surgery. And going beyond radiography, just so you're aware, as far as 2D radiography, we have our sensors. We have our HD sensors, we have our wave sensors for intraoral imaging, and also new to our product family is our EasyCam, our intraoral camera as well, okay? Now, moving on from here, let's talk a little bit about some of the drawbacks as far as 2D radiography. And this extends not only to panorama, but to PA usage, as well as cephalmetrics that we just saw here a moment ago. And just as a quick side note, when I'm talking about, some of the drawbacks, what we're really referring to is primarily the inherent magnification, or what often is referred to as distortion in your panorama image. And as I said, this extends to all 2D radiography, not just Vatech. This is universal across all 2D imaging. Because really what we're dealing with is an X-ray source and our sensor, which is basically capturing our light from the X-ray tube to generate these images, okay? So here are a couple of examples I want to be aware of. For instance, let's say we take a panorama film image on a patient, let's say on June 1st of last year, and the patient is considering doing an implant. Well, we take our panorama image, we utilize a calibration tool, we get a measurement of, let's say, 10.7 millimeters from the ridge down to the superior border of our nerve, okay? Let's say the patient decides that I'm gonna hold off doing an implant, and I'll come back in again in 6 months or so from their cleaning, and we'll reassess it then. Well, patient comes back in, let's say in January, and you do another panorama image. Patient may be positioned slightly differently, okay? And now you do a measurement. Now you come up with a height from the ridge to the superior border of the nerve that's now 12.5 millimeters, okay? So what happens in this case here is the fact that based on the positioning of our anatomy, as again relates to our center and our X-ray tube, can cause various magnifications and compression of our anatomy. So we have to be aware of these artifacts that are inherent to all 2D radiography. And this extends not only to panorama, as I mentioned a moment ago, but we want to be aware of how this can cause potential injury for our patient if we rely on 2D radiography as our sole source for treatment planning, in this case here, like for an implant. When we start talking about intraoral sensors, okay, everyone I'm sure is familiar with about the proper alignment, whether using a parallel technique or using a bisecting technique. Again, it's all because we want to make sure that we help offset how much foreshortening or lengthening you're going to see of our anatomy. Okay, so often see offices that will do something similar to this, where they'll place a bearing, okay, pack in a wax rope, place it in the socket where they want to measure. Well, if they position the sensor properly, they could certainly get an accurate height as far as how much bone they have to work with. Okay. However, if they don't adhere to the two basic principles as far as alignment, where maybe the the sensor is not aligned properly, you could get a foreshortening, and you get a situation where you get a false positive, so to speak, as far as how much bone you have to work with when placing your treatment planning for implant. Okay, going on from here, okay? How the center is being aligned, okay, can also create a false positive, so to speak. So the image on the left, which, as a side note, is not a Vatech image, it's one I found on the internet, where it appears that the distal roots are in contact with that implant. Well, that could very well be the case. However, depending on how that center or film is being aligned, could create this sense of superimposition of these distal roots on top of or in contact with the roots or the threads of my implant. The image on the right might be more representative, because now I can see a clear separation between the roots of my teeth and the threads of the implant. So when we start talking about DICOM, Digital Imaging Communication in Medicine, CBCT, this is where it creates a differentiation between 2D radiography and 3D. Because now when we start looking at anatomy and we start measuring, we want to get bone height, we want to get our bone width, we're now looking at the anatomy on what we call 1-to-1 scale, which means that these dimensions here are accurate down to the proportions of the anatomy of that particular human being that we are taking our scan, which greatly increases our treatment planning, which then is also then going to greatly increase the success of our surgery as well. So what does that mean to you then in terms of CBCT? Okay, CBCT has no focal trough like 2D does, and again, this is universal. Every panorama system has a focal trough. It's a focal distance that ensures the anatomy is going to be focused and detailed. CBCT does not have that, so we don't need to worry about that from a 3D image capture point of view. We don't need to worry about compression or expansion of anatomy due to sensor alignment like you would using a intraoral sensor. All right, so with that being said, unless you have any questions here, I'll stop when we get to the end of this point and get to our cases. But in this case, one of the things, again, that I want to make sure that we dispel is the lingering myth that essentially all 3D imaging systems are the same. Okay? There's a vast difference among different types of technology. And this is, again, As a clinician or as a dental assistant, when you're talking to your patient, this is your opportunity to help educate the patient to understand that there are significant differences in terms of the type of 3D technology out there to help offset and hopefully reduce any fear or anxiety a patient has. Having been to several thousand offices over the years training, I've seen where patients are nervous, apprehensive, and if that's the case, they're not going to be necessarily as cooperative as they would be if they understood what's going on in terms of our image capture. So as an example, let's make sure we separate the two different types of 3D technology. The first one we're looking at here is something you would see typically in medical facility, okay, the helical or spiral type of 3D CT systems. Okay, in this case, if the patient would be lying down as shown in this illustration, and the X-ray source is going to be essentially a very thin beam of radiation that's rotating around our patient. Okay, as it's rotating around the patient, though, however, it basically needs to overlap the anatomy, and what happens when it's done, it's going to then stitch all this data together and create our 3D cylinder data. Well, the combination between the multiple rotations around the patient and the overlapping anatomy essentially creates an exponential effect as far as the dosage then to our patient. Right? So, looking at CBCT, as you probably already know for those that have 3D in your office, the imaging system is making a single rotation around the patient. Okay? Cone beam, meaning that it's a cone projection. So the patient is being positioned very similar to that of a panorama image. Okay. However, because it's using a cone beam type technology, it only requires making a single rotation around our patient to capture our 3D scan. All right, Dr. Oz. Okay. This is what often precipitates a lot of fear and anxiety, because sometimes information is being communicated in a way in very broad strokes that all 3D is the same. Well, we just talked about the fact that there's a significant difference between helical or spiral type CT in a medical type facility versus what a dental office would have. Okay. In addition to that, there's often the claim that 3D imaging systems are using far too much radiation. Well, a lot of that has to do with the fact of the type of radiation here, but also making sure that we properly educate our patient to understand the dosage differences between different radiograph type of sources. So this graph will help put things in proper perspective for yourself, but I'll show you a really easy way to help communicate this then to the patient. Okay, so let's start with the fact that on a daily basis, as human beings, we are being exposed to radiation on a 24-hour basis. So from the sun, from the water, the air, everything, there's always radiation around us. Okay, so the average daily background of radiation is about 8 microsieverts on a 24-hour basis. Okay, so let's use that as our baseline as compared to other type of effective doses. When we start talking about digital panorama, the microsievert radiation range can be anywhere to roughly 5 microsieverts up to about 15 microsieverts. Okay, depending on doing a partial pan, whether you're doing a child, doing an adult, depending on skin type, bone density, all the different factors. When we compare then to, let's say, high quality film panorama, now we're talking about anywhere between 3 to 5 times, even 8 times the amount of radiation that we get from daily background. So when talking to a patient, this is a great way to take these two examples into consideration. Rather than telling a patient that they're being exposed to, let's say, 14.9 microsieverts of radiation today, okay, well, it's probably gonna make more sense to them to tell them that you're using half to 2/3 amount of radiation than what they would get from film panorama, okay? Probably something a little easier for them to be able to interpret or compare to, rather than using absolute numbers. Now, when we start talking about cone beam technology, okay, so now we're talking about a range of roughly anywhere between 12 to 150 microsieverts of radiation. Okay, again, it's going to depend on the KVP and MA settings for our scan, also depending on the size of the scan as well. Now, let's take this in comparison to other types of images. For instance, doing a full mouth series. using film, okay? When you look at these numbers, you can see that we're then exposing the patient to 2 to almost 3 times the amount of radiation when doing a full mouth series using film as compared to doing a larger scale of or large size field of view for CBCT. Okay, again, help put things in proper perspective then for our patient. Lastly, medical CT. Okay, this to me is really going to be the differentiation between cone beam technology in the dental office versus medical CT that you're going to see in a medical facility. Okay, when we look at these numbers, you can see now we're talking about numbers that are almost 10 times the amount of radiation to capture the same region of anatomy as compared to cone beam. So when you break this down, let's do this from a comparison point of view. Okay, so again, looking at one medical CT from a dosage point of view would be equal to not 4, not 8, anywhere between 10 to 12 CBCT scans using cone beam technology. Okay, so this really helps explain to the patient what the dosage is going to be. Again, putting things in proper perspective, get better patient cooperation. Let's look at a smaller field of view, an 8x8 field of view, which captures the central dentition itself. This would be equal to that of doing a cross-country flight by plane. Okay, very simple comparison. And then doing, say, a smaller 5x5 scan would be equal to that of doing, let's say, either one film panorama or doing 2 to 4 film PAs. All right, so we talked about dosage. Now, when we also talk about capturing anatomy, there's often the concept, and this is probably something that was probably true maybe 10, 15 years ago, that CBCT just simply captured too much anatomy. And it's probably true because a lot of the CBCT systems that came out 15, 20 years ago really had maybe 1 or 2 different scan sizes to choose from. Our entire 3D product line has a number of different fields of view, as small as 5x5 all the way up to, let's say, 18x10, 17x15, and 21x19 as well, and everything else in between that. So when I talk about the term field of view or FOV, but for those that are maybe considering CBCT in their practice, let's make sure we understand what we're talking about. Okay, CBCT scan really from a very simplistic point of view is nothing more than just a cylinder of data. And that cylinder of data is basically one that is perfectly round. So the width and depth are always going to be the same number. Like in this example, the width in this case here is 16 centimeters, which means the depth of our scan is also then going to be 16 centimeters. The height of our scan is then 9 centimeters. All right. So when we talk about a scan, the first number in, at least as far as our product line, is always going to be the width and depth, and the second number is always going to be the height. So let's take a look at some of the options we have available to us and what would be applicable then for your practice. Okay. Looking at, let's say, a 21x19 with our premium device. Okay. Certainly relevant for doing a large cranium scan for oral surgery, orthodontics, TMJ, certainly for airway as well. 17x15. Okay. Again, certainly applicable for oral surgery, orthodontics, TMJ, airway, and certainly a multi-specialty office as well. Getting to a smaller field of view, like an 18x10. Okay. Certainly for dual arch scans, applicable for all specialties. 16x9, just slightly smaller than that. Also relevant for doing, let's say, a dual arch scan is for all specialties as well. Going down to a smaller field of view, like a 10x9 or 12x9 anatomical, which is specific to our smart device product line. Certainly relevant for doing a dual arch scan, great for GPs, OMS, ortho, and multi-specialty type practices. 8x9. Now we're getting down to a field of view that would be generally considered the minimum scan size for those that are looking to incorporate surgical guides within their office for implantology. Most scans, most implant or guide manufacturers generally want to have a field of view at least 8 centimeters in diameter to work with to capture up to and maybe perhaps past the second molars when doing a surgical guide. Okay, getting down to something like an 8x5. Okay, now we're looking at something that's scanning just the upper arch, where I'm looking at the impaction of a canine tooth. Okay, and then getting down to a smaller field of view, as I mentioned, every one of our 3D devices includes the ability to capture a 5x5 field of view to do a specific area, like for endo use, or doing like a single implant, as you see in this example here. Okay. Again, continuing in terms of our discussion about separating myth from reality. Okay. Many years ago, a lot of the 3D scans that were captured with devices were proprietary, which meant that it could only be viewed with the imaging software associated with that particular manufacturer. Okay. Well, that made it much more difficult to be able to share data with either a guide manufacturer, with a radiologist, to a referring dentist down the street. Well, in terms of the evolution of 3D, there's been a lot of changes within the dental community when it comes to that. And in particular, for our particular devices, all of our CBCT devices capture scans in what we call a DICOM 3 format, which in most generic terms, it means it's basically the JPEG version of the 3D world, which means that it's essentially universal across all platforms. Whether you want to be able to use this 3D scan in other platforms, such as using Dolphin, using Blue Sky Bio, Anatomage, and even Code Diagnostics as well. So it's universal to be able to use within all these various platforms. The other myth that's out there too, in terms of communication and being able to do file sharing, is the difficulty of being able to send, let's say, a CBCT scan, which can be anywhere between, let's say, 200 to 800 megabytes in size. Well, certainly you can't email that. Some offices still use disks or put it on a thumb drive, which is certainly an option. However, we're always trying to find ways to streamline the process to be able to communicate and send data from, let's say, your office to a company you want to partner with that can generate guides for you or generate radiology reports. Well, we've partnered with a company called 3D Diagnostics. We often refer to as 3DDX. And there's an internal portal within our software that will then allow you to send a scan through our software directly to 3DDX. And basically what you do is complete the screen that you see right here. And I'll demonstrate this here in a little while. And once you complete it, upload it, they will essentially get an email at 3DDX saying you sent them a scan. You will then get a confirmation email that the scan has been sent. The dentist that is certified to review these scans and generate the guide will then schedule a consultation with you to review your plan, make recommendations if needed in terms of your implant plan for your guide that you're going to be using for your surgery, and then fabricate the guide for you. And with a company like 3DDX, it's kind of what I consider a la carte type of company, because what you have the ability to do is decide how much of this design and fabrication you want to take on yourself versus how much you want to delegate to a company like 3DDX. Meaning that you can send them the DICOM scan, you can send them an actual stone model, you can send a digitized stone model to them. They can fabricate the guide for you, or I should say design the guide and email the guide to you. And then if you have a 3D printer in your office, to be able to print it out. If you don't want to be bothered with that aspect of it, so to speak, they can print that for you and take care of the entire process, and you'll essentially get a guide in the mail that you then use then for your surgery and even your guide kit. Now, with that being said, if there are no questions, we'll go ahead and we're going to jump right into what I would call the unleashing aspect of as far as the benefits for CBCT in the dental practice itself. Okay. Now, when I use the term curing blindness, so obviously we're not an eye care clinic, we're not optometrists, but I really feel that when we start exploring the benefits of CBCT in dental practice, you're going to see as if you're seeing things for the first time that really probably were not even perceptible looking at 2D radiography. So I've got a number of examples we're going to take a look at. And again, as you have questions, we'll do a kind of a pause at the end of each case. If you have any questions, I'll be more than happy to explain in greater detail. And any questions you have, we can certainly address that at the end of our lecture here as well. So let's start by doing this. Several months ago on social media, this picture was being circulated with the question, do you see a bird or a goat? Okay, and I was really amazed at the number of people that thought this was a goat and how many people thought this was a bird. Depending on your perception and how your eyes interpret what you're seeing, I can see both. For instance, is it a goat? Well, if I look at it, maybe that's the mouth of our goat. Maybe that's the right eye of our goat looking at us. And perhaps that's the right ear of our goat as well. Or perhaps looking at this image, is it a bird? Well, if I look at it, it looks like the beak of our bird on the left-hand side. That certainly looks like the left eye of our bird. And this looks like the feathers of our bird. Okay. Now, when we look at the bigger picture, okay, we can see this is certainly a bird. Okay. So that's where I think is a good analogy because it helps us understand the benefits of being able to see a greater picture, not only from a 2D point of view, but being able to look at it from a 360-degree point of view in terms of making accurate assessment when diagnosing as well as generating your treatment plan. So with that being said, let's go ahead and we'll jump right into case number 1. Okay, this CBCT scan was captured with our green CT. It's a 5x5 scan, and this one is a scan that was taken of a patient who initially came in the symptomatic pain in the upper right quadrant. Okay, patient age 67, and they did a full mouth series. And when they evaluated these FMX images, it was fairly inconclusive to a certain extent as to where the extent of the symptomatic pain is, because pain, they could say, well, it's coming from my molar, well, it's coming from, my canine tooth or my lateral. But really, where the pain may be perceived by the patient may not be where it's actually, being created or the source of it. Okay, so looking at these images, obviously there's a lot of superimposition or cortical bone, but it looks like there's a little bit of asymmetry in the bone surrounding the distal region of tooth number 4 in this case. Now, we look at comparison, let's say, on the left-hand side of our anatomy, okay, where I can see better defined sinus floor, looking at regions 12 through 15. And then as we start comparing, let's say, both sides of our anatomy simultaneously, it may seem a little more obvious that there's something going on, certainly for tooth number 4. So the dentist decided, well, let's take a greater look at this, where we can then cut past the superimposition of cortical bone that is perhaps creating a superimposition outside of this region right there. And when we did the 3D scan, in this case here, again being a 5x5 scan for sites 3 through 4, we could definitely see what appeared to be lesions for tooth numbers 3 and number 4. So it could be something as a benign lesion. Looks like the walls of this are fairly well corticated. Okay, but what the doctor wanted to do was look at the extent of this. Is this treatable using antibiotics, or is there not enough bone to be able to recover this? May look at doing artificial bone and placing an implant. So one of the tools that we have within our software is called the oblique tool. And I want to demonstrate this through one of the many videos that I have here. And in this particular case, what I've done is position this so that I'm positioned at the furcation essentially between the distal and mesial root here of tooth number 3. And I'm going to play this video and revolving around this. And Jim, certainly feel free to chime in if you have anything you want to add to this that identifies this tool as I'm using it going around this particular tooth.
Well, and I think this is an applicable tool not only to our endo case here, but really all aspects of the Vatech software, where you can position this over implants, over different other third molars, and get a 360-degree rotation around that desired area.
Absolutely. And you may not even notice it necessarily, but if I bring my mouse, I don't know if you can see my mouse on here, but you can see there's communication now going on between the buccal-cortical plate and the cheek. That certainly is not evident when looking at the PA itself, and then you can see a better extent as far as how it's communicating perhaps either with tooth number 3 or even going into the sinus cavity here as well. As evident then, if I go to the next one where I move the oblique tool up to the center of the root of tooth number 4 and did the same rotation going around there as well. So that way I can look at the extent of this to see how much bone loss there is as it extends to the mesial distal buccal, as well as even the lingual part of the root, or the bone around that root itself. I would say this is probably one of the most underutilized tools, I think, within the 3D software itself, especially if you're looking for endo cases or like a failed endo in this case here.
I agree. Yeah, this is oblique tool is very applicable, and it should show that communication on that buccal aspect there.
Absolutely. Okay, so let's go ahead and move on from here. So let's look at case number 2. Okay, this scan was taken with our green CT, 18 by 10 field of view. And as I get into this was a CBCT scan taken on a female, 50 years old, who was considering doing an implant at site number 19. Well, let's assume for a moment that this was a panorama image and I'm looking at just the view, looking from the buccal aspect, right? Where I can see the ridge, I can see where I've identified the inferior nerve, and I have a measurement going from the ridge to the superior border of our nerve. So I have roughly about 10 millimeters to work with, okay? Well, if I was looking at just a panorama view, I may feel that I have enough bone to work with. But now that I have 3D, now I can generate that cross-sectional view. And when I do that, I've now revealed where I've got a lingual concavity or a lingual fossa here, which can greatly impact what type of implant I'm going to use. Rather than going from, let's say, a 10 millimeter implant, I may have to drop down to a 7 or 8 millimeter implant now because of the lack of bone I have based on how I'm going to be angling my implant. And to show you how quickly this is to identify from a 3D point of view, here's another quick video where I utilized the 3D pane part of the software, where I was able to take this navigation pane, left click, and I was able to drag it over into the site that I wanted to evaluate. And I'm going to use the toggle to rotate my sectional lines to basically match the angle that I want to place my implant, either to tooth number 18 or 19, and then based on my premolar. Then as I look at my view, I'm going to double click and even hit my space bar to open up that view. I'll even maximize the sharpness on this and then measure my bone. I'll measure from buccal to lingual. I'll then measure there to the lingual fossa or concavity that I've got, and then measure then to the superior border of my nerve. So now I've got a much better representation as far as how much bone I have to work with in that site where I want to do an implant, which from a 2D point of view, I can never get that type of accuracy. Okay, so extending the conversation further. So the number that I often use when looking at CBCT is 80%. And what does that mean? It basically means that when you're checking a CBCT scan of a patient, CBCT data contains, in general, about 80% of the time has another secondary or incidental findings within that data itself. And here's a perfect example of that, which is evident in case number 3. Patient came in, and this was taken with a smart imaging system. Patient was 19 years old and had multiple asymptomatic regions that were discovered when navigating through the CBCT scan itself. Now, I believe the patient came in initially because the patient was symptomatic, I believe, in tooth number 19. And so you'll see in this video that we go through here again, where we navigated across, and we're able to quickly identify that there was a fracture in this treated tooth. So when doing a PA image of this tooth, it may not have been nearly as evident to see as it would be as we do our 3D scan, where now, again, utilizing a tool similar to that of the oblique tool, where I can rotate around that root 360 degrees and then identify that fractured root within the anatomy itself. But also using this tool, I was able to identify what looked like a mandibular lesion between teeth numbers 30 and 31, and then even navigating with my navigation pane to the upper left quadrant, looking into the sinus cavity. As I scroll through there, I see what looks to be a potential cyst identified in the left sinus cavity. So maybe something that would be referred out then to an oral surgeon, okay? Or not a surgeon, but perhaps an ENT for that. Okay. So you can see by finding these additional incidental findings, even though they are asymptomatic right now, by referring this out to either an oral surgeon where we see that lesion, or perhaps to an ENT where we see that potential cyst in the left sinus cavity, can really help improve the overall health of our patient. So we partner with a lot of different sources out there, and one of the greatest resources that we recommend is CBCT readers. I mentioned the name Dr. Vijay Parashar, who generated this document for us, identifying the 17 anatomical regions that are identified in a panorama image. Partnered with this company, CBCT readers, where you can upload a CBCT scan to them, and they can assist you to identify these artifacts, incidental findings, secondary findings, and so forth that were observed within the CBCT scan itself. Okay, moving on then to case number 4. So when we're looking at OSA, what I'm referring to is obstructive sleep apnea, and referring to what's called a paradigm shift. I'll talk about that just a little bit later in terms of this particular case, but in this particular situation, this was a 21/19 field of view that was captured with our premium device. And again, this was a patient that came in for an implant consult for sites numbers 19 and 30. And initially, the scan was taken. The CBCT scan was treatment planned. There was certainly enough bone to support the threads of an implant at both sites numbers 19 and for number 30, I guess it was over there. And it wasn't until they did a further evaluation of the CBCT scan when they came across what could be a potential issue as far as the patient's airway. So in this screen capture, you can see in its red area what appears to be a constricted area of our airspace. So in this next video, I've gone through the steps to recreate what we see in this slide right here. So let's go ahead and get started with that. And I'll kind of walk through the steps to generate this. And you'll see it's a very simple process to do this, and great communication then tool with your patient. So I clicked on the measure airway icon. I measured from the floor of the sinus to the base of my epiglottis. As you can see in those regions, which is highlighted or outlined both the coronal, sagittal, and in my axial views. And I'm going to hit the enter key to maximize my 3D view. And we're going to work with this view specifically. And you see I right clicked and slid it off to the side to use that right area as kind of a workspace. And I'm going to left click to kind of rotate around and basically create kind of an oblique view of my anatomy. I clicked and I applied my soft tissue. And now I'm going to use a tool called clipping. And I'm going to clip from the sagittal region, starting from the left-hand side, and slide all the way across, and I'm going to stop when I get to the midline. Now that I've done that, what I'll do is right-click on that airway region, left-click on the option that says measurement plane, slide that over to the right-hand side, which I now have as my workspace. And you can clearly see what we've got to work with here. Let me minimize this for a moment, trying to see this. Go back just a tad here. So if I go right here, you can see in this airspace, we're talking about the airspace about the size of a cocktail straw. So you imagine this person is a male, 50 years old. Certainly difficulties this person could potentially have in terms of a potential sleep obstruction, considering the fact that this patient is standing up at the time the scan is being taken. So from a talking point of view with the patient, you can tell the patient certainly this is something that you would see, this is an ideal circumstance. You're standing up, your airway should be as wide as point for the most part. So you can just imagine the potential issue you could have when you're sleeping. You're sleeping on your back and so forth, where your tongue is more at rest and causing greater constriction of the airspace itself. So, as I talk about the paradigm shift, let me go back one slide here. Oops, bear with me. Okay. So, when I talk about paradigm shift, what I'm referring to is this. 15 years ago, Dr. William Dement really started exploring OSA and did a trial back 15 years ago and had the conclusion that there's no other chronic disease that afflicts more Americans than apnea, and put it into as a category being potential fatal disorder. So how does that apply to the dental community as far as this paradigm shift? Well, really, for the most part, most if not all dentists look at patients from the top down. They look at the teeth, they look at the occlusion, they look at grinding, clutching, TMJ, bruxism, and so forth, and airway be last. Okay. Well, because we're at a point now where OSA is really considered an epidemic by many in terms of the impact it's having on overall health of our population, the paradigm shift encourages dentists to flip this around. Okay? Rather than making the teeth the primary focus of your examination, the airway should be the centric focus of your evaluation of your patient. And this is a great opportunity to talk about the event that Dr. Tucker is going to be doing next month, because he's going to be talking about this in greater detail than I will tonight, talking about grinding, bruxism, doing an implant case, and the potential failure because the airway is not being properly assessed to see if the patient is a candidate for sleep apnea, if they're grinding or clenching in their sleep and so forth. These are things that need to be evaluated as part of the whole health of our patient, and not just focusing on just the teeth or occlusion and so forth. All right. So among the various KOLs or thought leaders that we partner with, Dr. Michael Gelb, he's actually the person that I kind of borrowed this paradigm shift terminology from, because this is really the backbone of everything he does within his practice when evaluating TMJ, airway, is looking at the airway first, and then from there determining what needs to be done from an airway point of view before considering other dental treatment within his practice. Okay, so in the beginning of the lecture, I was talking about this 10% market of retained dentures. Okay, so certainly from a denture point of view, if we look at it just from a pure number point of view, let's look at the total population in the US. Those that responded to this survey indicated that 41 million US citizens or people in the US have one or more dentures in their mouth. When we look at that as a percentage, that's 10% of the patients coming into our office that are currently wearing dentures. So there's a 10% market that we have the ability to kind of tap into, so to speak. So this kind of takes the conversation to the next level, so to speak. So for those of you that have really kind of maxed out in terms of things you've done with your CBCT in your office, and you want to be able to consider maybe more complex ways to use CBCT, this is certainly a great way to do it. And there's certainly ways to streamline it and be able to partner with others as well to make it efficient and make it successful then within your practice as well. So for instance, when we talk about the cost, okay, so the average cost for a denture is anywhere between $4,000 to $6,000, even higher than that, okay, depending on the type of denture, how many implants you're using, and so forth, okay. So from that standpoint, this is where it's an opportunity for you to have this conversation with the patient, okay. Obviously, patients who are currently wearing dentures, stuck using denture adhesives, using denture pads and cushions to help offset the pain they have on a daily basis having to wear dentures. Okay. And of course, the constant embarrassment of having to deal with dentures as well. So this is an opportunity to have this conversation with the patient. And this is one example of the many talking points that you can use in terms of moving away from a removable denture, which is considered kind of the low-tech tooth replacement, to a more state-of-the-art tooth replacement as retained or implant-supported denture. Okay. Some of the talking points that would certainly be recommended, such as the first one, okay, the dentures being more of an older technology, kind of a last resort for a patient, whereas using a implant-supported denture, now looking at considered kind of the gold standard for tooth replacement. Okay, one of the more important things that sometimes is overlooked, certainly implied and considered by patients, are those that have dentures, is the decreased bone quality and quantity over time. Whereas using implants, now you help retain both bone quantity and quality by using an implant-supported denture. Okay, and certainly because you're using a removable denture, no matter how much glue you're using, they're still relatively unstable and unreliable, whereas an implant supported denture is going to be far stronger and more stable and no slipping either. Okay, so the talking points go on and on from that. So if you were to have the opportunity to sit your patient down, talk to them about the benefits of going with implant supported denture, this is where the opportunity, whereas you can get them to case or to approve this case, and then you're faced with the next question: what do I do now? Okay, well, let's talk about that from the basics as far as what you need to be able to do within your practice to start scanning patients and looking at treatment planning for those that want to do a retained or implant supported denture. Number one, obviously, you need a denture. Number two, we want to have markers. We'll show that in just a moment. That's used to place on the denture itself. And number three, you need access to have a CBCT imaging system within your office. Okay, dual scan protocol. Okay, very common term that's used within the dental community, especially when it comes to doing implant-supported dentures. And in this case, what you're seeing in this example are where there are markers that are placed, okay, on the denture, on both the buccal, the palatal side as well, and it's a dual scan process. So what happens is this: you take a CBCT scan of just the denture, and then you take another CBCT scan of the denture in the patient's mouth. And then what happens from here, you then have a CBCT scan with the denture, and you can kind of see the little beads where the markers are within that DICOM scan. And we now have a scanned denture, which we've saved then as what we call an STL file, stereolithography type of file, that will then be merged with our DICOM scan itself. So once you have these two, this is where you have the ability now to do a number of things. I mentioned the company 3DDX or 3D Diagnostics earlier, okay? They can take this DICOM scan, they can take this denture, and they can fabricate the guide for you. We've also partnered with another company outside of Texas called Implant Concierge. They can essentially do the exact same thing. For those that want to be able to design and fabricate within your office, certainly you can have a software, either 3D diagnostics in your office or Blue Sky Bio in your office, and then you can print out your own guides then as well. Now, taking it back to a conversation I had earlier, where we're talking about using an internal portal and then partnering with 3D diagnostic using the 3DDX sender utility. This is where I have the ability where I can take the DICOM scan with the denture in place, as well as that DICOM scan of the denture itself, and upload and send both of those to 3D diagnostics simultaneously. So as part of that, what they would then do is take this DICOM of the denture itself, and they're simply going to then fabricate the guide for you. Or again, if you want to be able to print it out yourself, you certainly have the ability. So you can take the electronic file that they will send to you, again, as an STL file, and you can then print it out with your 3D printer in the office. But either way, you would then use that for your implant surgery itself. Left-hand side, we're seeing placing 4 implants. On the right, doing 6. You then get your new denture with the implant modified denture itself. And then the new denture with the implant connectors is put in place. And final result, we have a happy patient. Not only have a great smile, but they'd be even happier because now they'd be able to get rid of the C-bond or the secure or polygrip, as well as get rid of the cushions that they've been using to offset the pain from having to wear dentures every day. So in this video, again, I want to be able to help identify how quick and easy it is to be able to incorporate and partner with companies such as 3D Diagnostics to help you to implement this type of treatment planning within your office. Again, going after that 10% of the market that are wearing removable dentures and remove that, reduce that percentage by going with implant supported dentures instead. So let's go ahead and start it here. And in this case, what I'm going to do is start from the EasyDent software. And just as a quick side note, for those that want to view this in greater detail, this video actually came directly from our Customer Learning Center. So if you go to the 3DI portion of our Customer Learning Center, there is a 3 or 5 minute long video that goes through this step by step with audio and the pop-up, as you see here, to go through the steps to export the scan out, or the denture or stone model in this case, and then upload it then to 3D Diagnostics. So again, all I'm doing right now is going to the desktop of my computer, where I'm just going to create a folder that's going to either contain the stone model that I want to export or the denture that I took and export it out. So the process is exactly the same, it's just the output is slightly different. So now that I've saved it, now we'll go into our 3DI software, where I've got my 3D scan on the screen. And from here, I'll just go to my main menu. I'll scroll down to where it says Export CBCT, go across, and I'll click on 3DDX. Okay. So the first time you use it, just to stop for a moment here, okay? The first time you get into this part of the software, the sender utility, you'll need to populate it with your name, your contact information, and so forth, and it will then retain that information each time you use this utility. And if you have any questions about the services, there is a help button in the upper right-hand corner that will provide contact information, the types of services they offer, including radiology reports, implant guides, CAD/CAM services they offer as well. So we'll go ahead and skip a little bit further forward here. After populating the information, again, this is where I can then request to do a radiology report, either for airway, or if I want to identify it as a rule-out report for an implant case I'm looking to plan. And then if I'm doing an implant case, I can then simply put in the sites where I'm going to place my implant in the mandible as well as the maxillary arch, identify my surgery date, the implant kit that I want to use for this. Okay. Agree to the consultation that they need to schedule with you, and then move on to the second page, where now I can then choose that DICOM of the denture or stone model from the desktop of the computer. So I'm going to click on it. Let's go to the desktop of the computer, which is right here. Okay. I found my STL or the DICOM for my denture. I can now attach that. Acknowledge at the very bottom of that send to utility, click on send, and then through an internal portal on the internet, it will then upload the CBCT scan as well as the denture to 3D diagnostics. And again, you'll get an email confirmation verifying that that the scan and the denture was sent successfully to 3D diagnostics. So additional resources. Okay, for those that want to learn more about implant planning for retained dentures or just implants in general, Dr. Todd Engel in Charlotte, North Carolina currently has 4 mentor implant courses. And going to the next slide, you can do everything from intro to implant placement. It's a 3-day course for that in Charlotte. They have an M2 course, which is for intermediate or intermediate extraction and grafting. The M3, which is for advanced guided surgery, and full arch conversion, which is basically what we just did here as far as this implant supported guides. They do a 4-day full arch conversion course as well. Another resource on the West Coast, Dr. Michael Shear. There's a lot of online courses as well. There's a digital process. He's definitely what I consider one of the digital gurus within the dental community, and a great partner for Vatech America as well. And keeping in mind, referring back to 3D diagnostics. So you can certainly contact them for pricing, to verify the services that they have and what services you want to choose from their menu of services. So in summary, what we've done here so far, okay? We've gone through and separated 2D versus 3D radiography. Discussed in great detail the benefits of CBCT and treatment planning. And also looking at making sure to expand your view to consider incidental findings, looking at a CBCT scan. And talking about from an airway point of view, the paradigm shift that's currently occurring within the dental community itself, making airway the centric focus of our patient evaluation as it relates to overall patient health. And looking at permanent or implant retained dentures. Okay, so in this conversation so far, we've been talking about digital radiography. We're talking about implant planning. We talked about how to identify secondary findings, looking at airway and so forth. The greatest struggle that a lot of dentists have is the reality that I come across every day is this. Okay, I've got the patient sitting in my chair. How do I find time to treatment plan when I've got a full schedule? Well, what I want to have an opportunity to do is help kind of break this down a little bit in terms of finding an efficient and effective way to manage your caseload in terms of your patients that are coming into your office, the images you're capturing, both 2D and 3D, and also make suggestions which I feel will greatly improve your ability to create efficiency and effectiveness within your practice. Starting with this, the one thing that I really want to make sure that I stress wholeheartedly is making sure that whatever you do in your practice, whether again being implants, whether it be airway, whether it be doing case presentation and so forth, I don't want doctors to feel that it's a one-man or a one-band type of situation within the environment of your office. It's a team effort. Everybody needs to be involved. So when we do training with offices, we make sure to engage with everybody that's going to be involved with our technology to make sure they understand the benefits of it and how to use it effectively as well. So this is where you can empower and delegate other people in your office as well to understand how this technology can be used to better communicate, educate your patients to get increased case acceptance, and also manage your time more effectively as well. As an example, okay, when we're talking about image capture, one of the greatest things that we continue to focus on is image quality. Your time is best suited when you are working with clean data. Again, whether it be 2D or 3D, but certainly 3D data. Making sure that your team understands how essential it is to capture good data for you to work with. Perfect example, okay? When I'm taking a 3D scan, the two things I want to be able to do is this. Regardless of whether I'm going to treatment plan while the patient's sitting in the chair, or if I decide, you know what, I'm backlogged today, I'm double booked, I can't treatment plan this right now, I want to take the CBCT scan, evaluate it later, and have the patient come back in and do the case presentation in our consult room. Well, the two things that I would strongly recommend doing before you ever discharge a patient from your office is this. Number one, verify that you capture the region of interest, ROI. Number two, verify the CBCT is diagnostic, okay? I worked with an office recently, and the doctor called me. He was frustrated because he was having difficulty trying to identify maybe the nerve and the mandible. And I connected with the doctor, looking at a CBCT scan, and it looks similar to this. To the trained eye, it's clear that the patient moved during image capture. To some doctors that may be looking at it for the first time, it may not be as obvious. Just a quick identification, when you're looking at a CBCT scan, and I'm seeing what looks like a ghosting effect, where I see two cortical plates, buccal cortical wall right there in the mandible. That's certainly a clear indication. When I see what looks like kind of a streaking effect going on throughout the CBCT scan, that's also a clear indication the patient moved during the scan itself. So to avoid bringing the patient back in after you've taken the scan, you looked at it at the end of the day, I strongly recommend at least spend just 1 minute, 2 minutes, open a CBCT scan and evaluate it for those 2 points. Verify you captured the intended interest that you're looking to evaluate and treatment plan, and also make sure that's a diagnostic image. So in this case, the doctor was good enough to look at the scan before discharging the patient, realize the scan was not usable, okay? And they took another CBCT scan. So this is the exact same patient. This time the patient remained stable and did not move. I will say, it doesn't really matter whether it's a Vatech device or any other competitive CBCT system. The Achilles heel really of any CBCT is movement. Because if you think about it, the anatomy is being scanned 360 degrees going all the way around the anatomy. So let's say, for instance, a central incisor is being scanned, and that central incisor moves during image capture. Well, what's going to happen? That central incisor is going to appear in multiple places within our CBCT scan, as indicated in this screenshot right here. Okay, so it's absolutely essential the patient does not move. Even movement of a few millimeters can really have adverse effect on image quality. Another quick example, just because I want to make sure that we're clear on this. I go to some areas where the demographics of the patients coming in there to their office is fairly elderly. Maybe perhaps Parkinson's may be a factor in making it more difficult for the patient to stay stable. There are a lot of offices that I've been to that keep a chair in their in the exam room, or sorry, the X-ray room. And when the patient comes in, I'll sit the patient down in a chair, bring the machine down to them, and take the CBCT scan that way. By moving that potential movement of the legs or knees and so forth, increase the likelihood of getting a successful CBCT scan. Okay, another thing. When evaluating a CBCT scan, this is often a question we get from our Vatech family where the condyles are missing from the CBCT scan. Well, by looking at the CBCT, I can quickly identify the patient was not being positioned properly for CBCT. If the patient was being positioned for doing, let's say, a 2D panorama view, sure, I think this patient probably will be positioned fine, because what I want to see for a panorama image is about a 5 to 10 degree inclination of our occlusal plane, which I can see right there. So for a pan, that's great. This is not what we want to see as far as our standard for CBCT, okay? And as an example, this is probably how the patient was positioned within the device itself. That dotted red line indicates the patient's occlusal plane. The solid red line identifies what the standard should be for positioning for a CBCT scan. And as you look at the dotted line here at the top, you can see how the condyles are going off the top border of that data. Well, if those condyles are not part of that data, that cylinder we looked at earlier, there's no way to retrieve it or view it within the 3D planning software itself. So standard protocol for CBCT is a flat occlusion. Okay? Quickest way to do that, before image capture, have the patient smile, and the cusps of the teeth should be parallel to the floor, as you see in this example right here. And this is actually the exact same patient, just positioned properly. And if you look at the condyles, they're almost about 1.5 or 2 centimeters below the superior border of our CBCT scan. And look at the mandible. Notice how it's clearly defined. You can see the entire mandible. Whereas I have had doctors that call me and say, Len, you know, how come the mandible's gone? It looks like there's no bone there. Well, within 3D technology or 3D software, we're always looking at depth of anatomy. So in this case, the thickness of anatomy that we chose to view to generate this view didn't include that region of the mandible itself. So it appears that there's no bone there. Okay? Nothing wrong with the data. It could be manipulated to generate a better view, but it was determined to take another CBCT scan of the patient, and by doing so, the occlusal plane was flat, as you see here. So now the condyles are well below the top border of the scan, which is essential. If you're doing airway assessment, very often you need to be able to see the condyles, airway, the epiglottis, to be able to measure the entire airway. But this is the standard patient positioning for doing CBCT in your office. So I stress this here because it's probably the top inconsistency that we come across when it comes to image capture that can really create problems in terms of trying to verify that you captured the intended region of anatomy and making it easier for you as a clinician to treatment plan this. Okay, so case planning. Again, when it comes to treatment planning this presentation is designed to speak to those that are considering CBCT, those that have just gotten CBCT in their office, those that had it for a while, and those are even experts. So for those of you that have just perhaps incorporated CBCT in your office and using the gauge as maybe feeling less than 100% confident when it comes to navigating the 3D software, I strongly recommend using your private office, even first for a couple minutes, to evaluate, and if you have the opportunity to treatment plan your case rather than doing it in front of the patient. The feedback I get almost universally from doctors that I train who have just incorporated 3D in their office, they really feel apprehensive talking in front of a patient and navigating the software, for fear that by maybe not moving the software correctly or making a mistake, you could lose confidence in your patient. Well, if you're losing confidence in your patient, there's a good likelihood you're not going to get the type of case acceptance that you're looking for. So from that perspective, if you can separate yourself from the patient just for a few minutes to navigate the scan, again, even if it's just to verify that you captured the intended region of anatomy, making sure it's a clear, sharp image and the patient was stable during image capture, that's ideal. But if you can just spend a few minutes, as indicated in the previous cases, you notice that it literally only took me 1 or 2 minutes to go through, navigate, even do basic treatment planning of our case to the point where I can even present that then to the patient. So taking it one step further, okay? So let's say I've gone through, I'm in my private office, okay? I placed, 4 virtual implants in the anterior region of this patient's arch. The patient was a trauma patient here. And what I want to do next is this. What I want to do is show you from here how we can take images from the 3D software, capture them, and what it's going to do is automatically add snapshots to the patient chart in the EasyDent software itself. Why is that important? Well, what you have the ability to do then from here, let me go back to the previous scan for a moment. What I have the ability then to do from here is take these snapshots and use that as a case presentation then to the patient. Okay, so rather than navigating the software live in front of the patient, well, I can take my completed treatment plan, use the camera tool in the software, capture my images, and then present them to the patient. So in this example, I'm going to go through this here right now. So let's play the video. Okay, so here I am. I'm in the software, and I highlight the caption button, which is really my best friend when it comes to taking images, and I use it a lot. So what I did just now was click on it once, and I captured that entire MPR view. I hit the Enter key to maximize that 3D rendering. I made it kind of an oblique view, looking at it from this angle with the stone model in place. I clicked on the camera again, and now I'm going to right-click. I'm going to hide this stone model that I've scanned. So looking at just the dentition and my virtual implants. I'll rotate it back around again, and let's go ahead and I'll grab this now a third image of my anatomy, which I'll then use for more case presentation. With that being said, let's go over to the 3D pan view, and what I want to do is hit the Enter key in my section views down below, and I'm going to then grab snapshots of my implants that I've placed. So I hit the Enter key to maximize my pan view. I'll grab a snapshot of that as well. I hit the Enter key to go back to my previous layout that I had for my 3D pan, and I'll hit the Enter key here again for site number 8. I'll double left click, and now I'm looking at the implant at just that site. I'll click on my camera now for probably the 5th or 6th time now in that region. And now I'm simply using the center wheel of my mouse, and I'm rotating through this. And now I'm doing a screenshot of the virtual implant for tooth number 7. So now that I've done that, now I've got 7 images that I've captured from the 3D software. So let's stop just for a moment here. So again, I want to try and put things in perspective as far as where you would be from a workflow point of view in your office, right? So imagine a moment ago, if I go back to this right here, you're in your private office. I treatment planned all this. I clicked on the camera 7 times. I captured all these images. All these images are now being saved, not only on my computer, but they're also being saved on every computer that has the EasyDent software installed on it, including the computers perhaps in your exam room and in your treatment coordinator room or your consult room. So now what I have the ability to do is take these snapshots, right? I can then present them to my patient. So let's stop here just for a moment again, okay? So all I did was click on the console button, and this is where you can engage other people in your office. So you can delegate this or empower someone such as your dental assistant or your treatment coordinator to say, hey, look, I just finished doing treatment planning for John Doe. Bring up the images and I'll be there in a minute to help explain what we're looking at as far as the treatment plan. Well, that person can then take these images, open up the console part of the software, and then all I need to do is simply left click from that thumbnail view at the bottom and then populate the frames I have within the console part of the software. And then lastly, what I'm going to do in that 4th window, I hit a drop-down list along the left-hand side in case you didn't notice that. And there are multiple categories. I think there's like 9 categories and 1 custom category at the very bottom. And what I'm going to do is choose the category for implants. So we'll go ahead and play here again. I click on the implant category. And what I'm going to do is scroll across there until I get to the video. Let me go a little bit further forward here. There we go. Okay, so I found a video that matches the type of treatment plan that I'm looking to present to my patient. So patients are visual, and the more you can explain to a patient in a case that may cost, you know, $5, $10, $15,000, certainly you're probably going to get better case acceptance if you can explain to them the amount of time that goes into planning this and the reason why 3D technology is so much more beneficial, because now I can generate these type of cross-sectional views that I can't get from a 2D perspective, and being able to use a video like this just to help explain to the patient, okay, where you can be using a drill to kind of drill through the bone, and helps to explain to the patient what's included as part of this actual surgery itself. And I will say, just to pause for another moment, I have doctors that would say, oh my gosh, this is great. I can't wait to show this to my patients tomorrow. And I have some doctors say, you know what, there's some patients I wouldn't want to show this to. They'd probably pass out on me. Well, that's fine. Well, what you need to do is basically understand your patients. Okay, this is where having the conversation with the patient before even getting to this point, say, hey, you know what, here are the images I've got. You know, how much detail do you want me to go into in terms of explaining what is incorporated as part of doing this type of treatment? Look at just the images, that's fine. If they want to be further educated, like I'd want to be, and be able to see these education type videos, certainly I want to know what's involved to understand fully part of this type of treatment plan. And in addition to that, let's take it one step further, okay? Again, that's all about educating the patient. What I did in this example, I created a custom category, in this case here for Dr. Engel there in Charlotte, North Carolina. So again, trying to create some reality here. So let's say you have a patient sitting in the consult room or sitting in the exam chair, and you need a few minutes before you can engage with the patient, review the case with them. Well, perhaps give them a video that's going to help kind of explain to them what's involved as far as doing this type of implant. You can have testimonials perhaps from patients that you've captured. You can add them here as well, so you can utilize, you know, any one of these. I think there's almost 300 videos that are preloaded, as well as create an infinite number of additional custom videos, either from YouTube or ones you've got that you captured within your office itself. And so here we are, the video of Dr. Engel going through his treatment case. Okay. All right, so we're getting on just close to 6:30 right now, and I think I'm just about done with this end right here. So this helps explain in terms of incorporating the effectiveness and efficiency within your office to engage the patient through your consultations here, in the consultation room itself, or even the exam room itself. But I would strongly recommend, you know, doing the treatment planning at the point where you feel comfortable navigating with them. Otherwise, use the static snapshots and do your case treatment planning that way. And one last thing to request is to avoid using the x-ray room. This is a perfect example. Went to an office, the doctor was treatment planning on the acquisition PC when I came in there. And it's a different office, but an example came in where they needed to take a CBCT scan on the patient, so that, you know, interferes with your workflow, because now you have to take a break during your treatment planning, scan the patient before you go back there again. So I definitely recommend at least having the 3D software installed on at least one other computer in your office, preferably away from the patient, to do your treatment planning. Okay. So we're getting on just about 6:30 right now. So at this point, Jim and Paul, how are we doing on time?
And Len, we're good on time. If you have we have a few more minutes for you. Paul and I have been answering questions back and forth, and if anyone else has any other questions, feel free to use the chat or the question box. And then if you want to go ahead and continue with your presentation there, sure. Paul and I are handling all the questions that are coming in.
Awesome. About maybe 5 more minutes, I should be able to wrap things up. All right. So in the beginning, we also talked about what is the future of case planning within 3D software. So let me go back over here again. Oops. Oop, I'm back. Okay. So in terms of the future of case planning and presentation, a new tool that's available within the 3DI software is called a segment tool. And what this will allow you to do is quickly segment the entire arc automatically, and then using the tool called Auto or Smart Implant, I can then identify my site numbers, like I did in this case here for site number 7 and number 10. I did an extraction of those sites of these laterals that were never properly developed. And now I'm going to go ahead and place implants. And I'm actually going to place crowns on there as well for site number 7 and number 10 with my crown as well. Click on insert, and now automatically drop those 2 implants in place. Now I chose those specifically because I knew they needed to be edited. So if I right click on the crown, I can even change the size of my crown. If I want to bring it down into close to my dentition, I can left click on the implants themselves to line them up with the either the ridge or the rest of my arch. I can use my controller if I want to rotate either the crown, if I need to rotate or angle or change the angle of my implant, then I can do that as well. So again, all about creating efficiency and a quick way to treatment plan and use that for case presentation then to your patient. So the recommendation to have for all clinicians, those are part of our Vatech family. If you've had your imaging system for probably more than 6 months, I would definitely recommend going to our website, www.vatechamerica.com, to look at updating the EasyDent and the Easy3DI software. Every 6 months, we update the software, so it's recommended to go in there to update it. So either have that delegated to perhaps your IT people or your technical support team to download that from our website, which you can access through the service and support option at the top of that screen, and then navigating through the sections down with the red boxes where you can update the Easy Server, the 3D software, as well as the EasyDent software. So in summary, what we talked about is don't become a one-man or one-woman band. Okay, it's absolutely essential to get everybody engaged in your office to participate, to help support educating your patients, get better cooperation, and make it more efficient for you to be able to image capture, diagnose, treatment plan, and then present them to your patient. Okay, it's also essential to implement proper image capture protocols. And this extends for 2D, but certainly for 3D as well. Make sure that the team that is capturing images understands the proper protocols, because the more they can do to minimize movement of the patient, the greater stability they have, the better output you're going to have. So the layman term I often use is garbage in, garbage out. If you don't use the technology correctly, you're not going to get successful output on a consistent basis. You know, they often, example I often give as well is, you know, you go to, you know, a dealership and buy an expensive sports car, you can drive around first gear all day. Well, yeah, you're driving it, but you're not really maximizing the potential for it. So to maximize the potential for your investment, make sure the team that's using this imaging system is properly trained, understand the proper protocols for both 2D and 3D image capture. Okay. Separating self from the patient. Okay, this really relies more on those that are perhaps newer to 3D technology. If you don't feel comfortable navigating the software in front of the patient, strongly recommend separate yourself at least for just a couple of minutes. Evaluate the scan in your private office, where you can verify, number one, again, you captured the region of interest. Number two, you verify the patient was stable during image capture, so you have good quality scans to work with. Okay, and if you can have the ability to, certainly treatment plan. And you notice that in virtually all these videos that we showed tonight, none of them are really beyond 2 or 3 minutes. So you can quickly go in there to the 3D software. I especially like using the 3D pan tab of the software. So if you haven't utilized it, certainly go to our Customer Learning Center for that. We have over 2 hours of video content specific to just the 3D software itself. There's video tutorials in there for the various imaging systems we have in our product line. And as Jim and Paul indicated in the beginning of our session here tonight, they do the Fast Track Friday sessions and they'll go through those dates again, and also go to our website where those dates are being published there as well, to engage the team to understand these proper protocols to make sure that they're being efficient and utilizing and getting good images on a consistent basis. And lastly, use the consult room or exam room for your case presentation. Great opportunity to empower or delegate either the treatment coordinator, the dental assistant there in your office to help set that up, or help participate in the case presentation, or even bring up tutorial videos before you do your case presentation then to the patient. Okay? And update your software. Very important to do that. Typically every 6 months is ideal. And education, education, and again, education. Okay, with that being said, that wraps up my portion for our time tonight. And again, I wanted to thank everyone who participated in our session here this evening. It's been certainly a pleasure and honor to speak before you, and again, being the first person for the 2021 year. And again, wish everybody a healthy and prosperous new year. Thank you very much for your time.
Len, and thank you for coming on and being our presenter. A wealth of knowledge and some really good presentation as far as workflow, and a lot of tips and tricks and really applicable things for all aspects of CBCT users, 2D users, people looking to get into cone beam. Most of what you have said really kind of leads into our upcoming events. Fast Track Fridays series on the 3 Fridays, from sensor positioning, software workflow, making sure we're positioning our patients properly. We have these different tools and education for our users, or if anyone's really interested in getting into the Vatech product line. And then after that, you talked about OSA and implants and total dental health. Dr. John Tucker is going to talk specifically about that topic. Dr. Dale Miles is going to go further into that on implant success and how to prevent failures of what are we looking for in our CBCT scan, looking at the patient's overall dental health, and how does that affect the outcome and the patient's total health there. So we do have some really applicable topics coming up. Everybody can sign up on our website. You will also get a follow-up email with those links. And Len, like you said, all of this is being recorded, so you do have access to this after tonight's session there. To find those recordings for your device, we have our Customer Learning Center here for our imaging devices, the software. But down in the lower right, we do have our webinar. That's where everything's going to be recorded, and you can have access to this video and our library from last year, all of our videos there. Len, you mentioned about updating the software. Real quick thing on here, we do have our FAQ page for other common questions of, exporting, sanitizing the device, making sure everything's properly sanitized, and other workflow things there. So I would like to, Len, thank you. I would like to thank all of our Vatech family that joined us. Paul, thank you always for your support and your partnership in on these webinars. It's a pleasure working with both of you, and from the Vatech family to all of our users out there, we wish everyone a prosperous 2021, and we look forward to talking and seeing you soon. Thank you.
Thank you.